What if I told you that one of the most common hormonal disorders affecting women worldwide has been misdiagnosed, mismanaged, and almost completely misunderstood? And there is a very good chance your own doctor has given you only half the picture. Stay with me, because the next 12 minutes could change the way you understand your body forever. PCOS affects an estimated 13% of women of reproductive age globally who, 2023. Up to 70% remain undiagnosed, making it one of the most underdiagnosed conditions in women's medicine. You gain weight without explanation. Your periods are irregular, sometimes missing for months. You look in the mirror and see acne that should have disappeared after your teenage years. You feel exhausted, foggy, and anxious, and when you finally go to a doctor, they hand you a birth control pill and tell you to lose some weight. Sound familiar? If it does, you are not alone. Polycystic ovary syndrome, PCOS, is quietly affecting millions of women right now, and the tragedy is not just that it is so common. The tragedy is that most women living with it have no real idea what is actually happening inside their bodies. Today, we are going to fix that. We are going to talk about what PCOS actually is at a biological level, what its real symptoms look like, including the ones nobody tells you about, what science says you should be eating, and what treatments are genuinely backed by research. No fluff, no outdated advice, just the truth. And I am going to warn you right now, the symptom coming up at the 3-minute mark is the one that surprises women the most. Do not skip ahead. What is PCOS? The problem. Biology explained clearly. Let us start at the beginning. PCOS stands for polycystic ovary syndrome. Here is the first thing you need to know. The name itself is misleading. Despite what it suggests, you do not need to have cysts on your ovaries to be diagnosed with PCOS. What you do need is a combination of 3 key markers, and doctors use what is called the Rotterdam criteria to diagnose it. You need at least 2 of these 3, irregular or absent ovulation, elevated androgens, those are male hormones like testosterone, and polycystic ovaries visible on an ultrasound. That is it. 2 out of 3, which means millions of women with completely normal-looking ovaries still have PCOS, and they never know it because a doctor looked at their ultrasound, saw no cysts, and closed the case. The Rotterdam criteria, 2003, remain the gold standard for PCOS diagnosis. A 2021 meta-analysis in Human Reproduction Update found that up to 30% of women diagnosed via older knee criteria were reclassified under Rotterdam, meaning diagnostic accuracy has dramatically improved with the newer guidelines. So what is actually happening in the body? At its core, PCOS is a hormonal and metabolic disorder. The ovaries produce too many androgens. This hormonal chaos disrupts the normal cycle of egg maturation and release. The follicles, those fluid-filled sacs that hold eggs, start developing but never fully release. They just sit there, sometimes hardening into small cysts. Meanwhile, the body is often struggling with insulin resistance. The pancreas produces more and more insulin trying to manage blood sugar, and that excess insulin signals the ovaries to produce even more androgens. It becomes a vicious, self-reinforcing cycle. Research published in the Journal of Clinical Endocrinology and Metabolism found that approximately 65-70% of women with PCOS have insulin resistance, even those who are not overweight, a finding that fundamentally changes how we should approach treatment. Okay, we just covered the biology. But here is where it gets personal. Because the symptoms of PCOS go way beyond what most people think, and one of them is affecting your mental health right now. Symptoms. Agitation, the symptoms nobody talks about. When people think PCOS, they think irregular periods and maybe some acne. But the symptom list is far longer, and some of these will shock you. Let us go through them, the ones everyone knows and the ones that often go unspoken. Irregular or absent periods are usually the first red flag. But here is what is less discussed. Some women with PCOS have completely regular periods and still have the condition. So the absence of irregular periods does not mean you are safe. A 2019 review in Frontiers in Endocrinology found that approximately 20% of women with confirmed PCOS report regular menstrual cycles, highlighting a significant diagnostic blind spot. Hyperandrogenism, elevated male hormones, shows up on the skin and hair. We are talking about acne along the jaw and chin, excessive hair growth on the face, chest, and stomach, and paradoxically, hair thinning on the scalp. This happens because testosterone acts differently on different tissues. The same hormone that causes hair growth on the face causes hair loss on the head. Weight gain and difficulty losing weight. This one runs deep. Because of insulin resistance, the body stores more fat, particularly around the abdomen. And here is the cruel irony. Standard low-calorie dieting often backfires in women with PCOS because it can spike cortisol, which further disrupts insulin and hormones. We will come back to this in the diet section. Darkened skin patches, a condition called acanthosis nigricans, appearing around the neck, underarms, or groin. This is a direct sign of insulin resistance and is often completely overlooked. Diet sets the foundation, but it is not the only tool. In the next section, we are going into the treatments that are actually working for women right now, from the medication most doctors reach for first to the emerging approaches that research is finally validating. Treatment options. Solution. What actually works? Let us talk treatment. And the first thing to understand is that PCOS treatment is not one size fits all. It is goal dependent. Whether you are managing it to regulate your cycle, reduce acne, improve fertility, or lower long-term metabolic risk, the approach changes. So let us walk through the main categories. Hormonal contraceptives, the birth control pill, are the most commonly prescribed treatment. They work by suppressing androgen production and regulating the cycle. For many women, they are effective, particularly for managing acne and preventing endometrial hyperplasia, which is the buildup of the uterine lining that can occur without regular periods. But, and this is important, the pill masks symptoms rather than treating the underlying cause. The moment you stop, the hormonal imbalance returns. For women who are not currently seeking to manage fertility, this is often an acceptable trade-off. But it should be a fully informed choice, not the only option presented. Metformin is an insulin-sensitizing medication originally developed for type 2 diabetes, but it is now one of the most studied drugs for PCOS. It directly targets insulin resistance, which, as we established, is at the root of the hormonal cascade in most PCOS cases. Studies show it can improve ovulation, reduce androgen levels, and lower long-term risk of developing type 2 diabetes, which women with PCOS are at significantly elevated risk for. A 2020 Cochrane review, the gold standard of medical evidence synthesis, found that metformin improved ovulation rates and metabolic parameters in women with PCOS, with greatest benefit seen in women with confirmed insulin resistance. Spironolactone is an anti-androgen medication that directly blocks testosterone receptors. It is particularly effective for hirsutism, that unwanted facial and body hair, and for hormonal acne. It is often prescribed alongside the pill. The key downside is that it must be avoided during pregnancy due to risk of birth defect, so reliable contraception is necessary. For fertility specifically, letrozole has now overtaken clomiphene as the first-line ovulation induction agent for PCOS. A landmark 2014 NEJM trial found letrozole produced higher live birth rates than clomiphene in women with PCOS. It works by temporarily lowering estrogen to stimulate the pituitary to release more FSH, the hormone that drives egg development. The New England Journal of Medicine, et al., 2014 multi-center trial of 750 women with PCOS found that letrozole resulted in a 27.5% cumulative live birth rate compared to 19, 1% for clomiphene, a statistically significant difference. Lifestyle modification, and yes, this means structured exercise, is not just supportive care, it is active treatment. Multiple meta-analyses show that even a 5 to 10% reduction in body weight in overweight women with PCOS restores ovulatory function, reduces androgens, and improves insulin sensitivity more effectively than medication alone in some cases. Resistance training in particular improves insulin signaling in muscle tissue and should be part of any PCOS management plan. A 2019 meta-analysis in obesity reviews found that exercise alone, even without weight loss, significantly improved insulin sensitivity, androgen levels, and quality of life in women with PCOS, with resistance training showing the strongest hormonal effects. Emerging and complementary approaches worth knowing about, NAC N-acetylcysteine, has shown promising results in small trials as both an antioxidant and insulin sensitizer. Vitamin D deficiency is extremely common in PCOS, and correction has been linked to improved insulin resistance. Berberine, a plant compound, has been compared to metformin in preliminary studies with similar effects on insulin sensitivity, though larger trials are still needed. Mental health support is a treatment, not an afterthought. Given the threefold increase in depression and anxiety risk, therapy, particularly cognitive behavioral therapy, combined with PCOS-informed medical care, produces measurably better quality of life outcomes than medication management alone. If your doctor has never asked about your mental health in the context of your PCOS, bring it up yourself. We are almost at the end. But the final minute of this video has the one thing I want every woman watching to leave with. Do not click away. The empowered takeaway. Here is the truth about PCOS. It is not a life sentence. It is a condition that is deeply manageable when you understand what is actually driving it. The insulin resistance, the androgen excess, the inflammation, these are not random. They respond to targeted nutrition, appropriate exercise, evidence-based supplementation, and when needed, the right medications. The research is there. The tools are there. But managing PCOS requires you to be an informed, active participant in your own care. It requires asking your doctor about insulin testing, not just cycle regulation. It requires understanding that the birth control pill is one tool, not the only tool, and that real hormonal change comes from addressing root causes. And it requires giving yourself grace, because this is a complex, whole body condition that affects how you feel, how you look, and how you think, and none of that is your fault. If this video helped you understand PCOS in a way that nothing else has, share it with someone who needs it. Subscribe if you want more content like this, grounded in actual science, delivered in a way that respects your intelligence. And drop a comment below telling me which symptom surprised you most. I read every single one. I will see you in the next one.